on things that are good or bad and could be changed or said more clearly, so that things go well in Charlotte. So I think Kevin Harrell's going to go first. He's got two he's doing. The format's 3 minutes, right?
Yes, 3 minutes and then 2 minutes for questions.
Yeah, so we'll try to stick to that same format.
So just so everybody's aware of what's going on, they have a new thing this year where you can do a mini quick shot presentation instead of a poster, so that's what I've done, and so it's a video that just plays your slides, which is kind of frustrating, but that's what I'm going to be trying to get to happen up here. Good morning. My name is Kevin Harrell. I'm a third-year resident at the University of Tennessee, Chattanooga. And today I'm going to be presenting an interesting case of thoracoabdominal trauma that required pulmonary vein repair as well as splenectomy while the patient was on cardiopulmonary bypass. Simultaneous traumatic injuries of the thorax and abdomen have a high morbidity and mortality and can alter traditional management algorithms. Surgeons must first identify and treat the most life-threatening injuries and body cavities. Blunt avulsion injuries of the pulmonary vasculature are also rare and highly morbid. Most famously killing Princess Diana in 1997, these injuries require prompt surgical intervention and are rarely reported in the literature. Our patient is a 37-year-old male who fell from a 30-foot scaffold. He was initially responsive but intubated on scene by EMS for shortness of breath. He arrived to the trauma bay stable and his initial chest x-ray was clear, which is pictured. A fast exam and CT scan revealed pericardial fluid as well as a splenic laceration, which is also pictured. The patient was taken to the operating room where we began with a pericardial window, which demonstrated scant blood. A subsequent median sternotomy revealed a laceration to the right inferior pulmonary vein. The patient was placed on cardiopulmonary bypass after cardiothoracic surgery consultation, and the injury was repaired. Here you can see our intraoperative view with the right atrium, as well as the deep review of our repair and the right lung being retracted medially. After the repair, the patient was also noted to have increasing abdominal distension, and a splenectomy was performed while the patient was still on bypass. After this, bypass termination was begun for heparinization reversal due to continued non-surgical bleeding. The patient continued to be on massive transfusion protocol and had received 74 units of total blood products. The patient suffered a cardiac arrest and a manual cardiac massage was begun. Additional blood was delayed from the blood bank, and after several minutes, the patient was declared dead, and the attending surgeon left the operating room. After this, the cardiac perfusionist decided to empty the venous bypass chamber back into the patient, which caused sudden spontaneous return of circulation. Negative pressure wound dressings were placed on the chest and abdomen, and the patient was taken to the ICU. The patient had multiple concomitant injuries, such as left humerus fracture, right calcaneus fracture, rib fractures, and spine fractures. His chest and abdomen were eventually closed on post-op day 2 and 4 respectively, and he did require a tracheostomy. The patient was discharged to a skilled nursing facility on post-op day 22, neurologically intact and decannulated. As we can see in this case, simultaneous thoracic and abdominal trauma require rapid decision-making. Pulmonary vein injuries can present with initial stability before decompensation but require prompt surgical intervention. Also, newcomers to the trauma OR should be kept in constant communication, such as our perfusionist. This is, to our knowledge, the first splenectomy performed while on cardiopulmonary bypass. Thank you, and I'll be happy to take any questions.
3 minutes and 3 seconds. That's pretty good.
I didn't detect any major problems other than a few more rehearsals that might go a little smoother. Except for the last sentence, you said newcomers to the operating room, newcomers to the trauma OR, maybe.
I have that in my notes. Maybe I just didn't say it.
You said OR.
Okay.
This is a little thing, but I think unless there's a different spelling of calcaneus than I'm aware of, I think you misspelled calcaneus.
Well, it's too late for that, so
Oh,
it's been submitted. But
never
thank
mind
you.
then.
But never mind.
I don't know, I mean,
Use
Yeah, I think it went well. You're going pretty fast, but I think you kind of have to with the constraints of this. I don't know if there's a lot to be done about that.
So I've got a question. You said know your perfusionist. I didn't quite understand. Maybe it's just I don't understand trauma well enough, or perfusionists or whatever. But why do you have that as why does knowing your perfusionist what does that have to do with anything here?
Because we had ongoing conversations about we needed blood, and he was there the whole time. And then after the patient literally was dead, he said, "Oh, I have all this extra blood. What should I do with it?" And he emptied the bypass chamber, and then that's when the patient came back to life.
Yep.
So
I see.
he was just sort of, I guess, out of the loop, or as I meant to say, a newcomer to the trauma OR, and I guess didn't really know what was going on.
So for some of us that maybe aren't as familiar with the trauma OR, you might want to just mention that was sort of the key element here.
Okay.
Yeah.
Maybe be more direct about.
I'm trying not to throw him under the bus, but maybe I should a little bit more.
Yeah, because otherwise for people like me, I'm like, okay, well, he was just like packing up his instruments and didn't have anywhere else to put the blood and put it in the patient, and as opposed to
Okay.
your explanation.
So along those lines, maybe say something to the effect of the trauma has multitude of injuries and a number of different people can participate in the care who aren't familiar with the normal running of a trauma, and communication routes need to stay open between the personnel in the room, not know your perfusionists, because you're not going to. I mean, at a big hospital, you're not going to know
Right, of course.
who coming in and out. So, and it's not his fault per se, because he doesn't know the system and he wasn't communicated very well. And rarely do you put a trauma patient on bypass. So probably make that a little more general sounding of many people can participate and communication needs to be kept open.
Yes, sir.
You said it, but it sounds like the reason of the code that there's not blood that got there in a timely manner. But that, to me, got a little bit lost. It sounds like magically the patient just got better once they pumped it, which makes sense. But
I mean, that's like literally what happened.
yeah,
It was
but
like Lazarus. Dr. Maxwell was down the hall.
I guess make it a little more clear that the patient basically exsanguinated, died, and then was
Okay.
resanguinated. I don't know.
It's a good term. I might use that.
Insanguinated?
Did you consider also electrolyte abnormalities? You consider also the electrolyte abnormalities that show up in bypass? They use high test to stop the heart rate when the fusion would reinstate the bypass. Just maybe washed out of the heart and may have caused this to happen. So think about why it would have happened, not because you just had blood in the heart, unless you were bleeding IV fluid. Maybe consider that as a role.
Yeah, no, I'll go again.
Is there any, hold on. I mean, what's the importance of this being the only reported splenectomy on bypass? Okay, it's just the uniqueness. It's not,
just unique.
otherwise it's not a step in some direction that you're going or anything like that?
I don't think so.
Okay, all right.
There just are literally no report. There's nothing in the literature about that. But
That would be
It made it more difficult.
besides the patient coming back to life, and by the way, we took out a spleen.
all right, number 2. My presentations are actually back to back at the same kiosk that morning, so I'm going to have some sort of transition between the two, but we're just going to start over. So good morning again. My name is Kevin Harrell. I'm a third-year resident at the University of Tennessee, Chattanooga, and I'll be presenting on penetrating subclavian artery injuries this morning. Rare penetrating injuries to the subclavian artery are highly morbid due to its challenging anatomic location. Multiple surgical approaches can be used to access this deep structure, and multiple options are available to the trauma surgeon for damage control or definitive repair. We present a case series of 3 patients with penetrating subclavian artery injuries that were treated with various methods. Our first patient is a 22-year-old male who sustained a self-inflicted gunshot wound to the left chest, presenting with a cold and pulseless arm. He was stable on presentation, and a CTA pictured here showed active extravasation, as well as disruption of the left subclavian artery. He was taken to the operating room, and a subclavian approach was used. The artery was repaired with a PTFE interposition graft at the primary operation. The patient was discharged to a psychiatric facility with decreased motor and sensory function of the left arm and hand. Our second patient is a 26-year-old male with a similar self-inflicted gunshot wound to the left chest. He presented hypotensive and tachycardic with pulsatile bleeding from the wound. A chest tube was placed in the ER, massive transfusion protocol was started, and the patient was taken directly to the operating room. An infraclavicular approach was also used and extended onto the arm, which revealed a complete transection at the subclavian axillary junction with a 2.5 centimeter defect. A temporizing 12 French Argyle shunt was placed, and a volar forearm fasciotomy with an S-shaped incision was performed. He was later taken for definitive repair with a reverse saphenous vein graft. He was also discharged to a psychiatric facility with decreased fine motor function of the left hand and significant nerve pain. Patient number 3 is a 39-year-old male who presented in extremis with CPR in progress after sustaining a gunshot wound to the back. An ED thoracotomy was performed with massive bleeding. Manual compression was held in the chest while the patient was transported to the operating room. Once there, the incision was extended to a clamshell thoracotomy, and a proximal injury to the subclavian artery was identified. A damage control approach was selected with proximal ligation of the artery, as seen in our intraoperative photo. He was taken to the ICU for resuscitation, and a subclavian carotid bypass was subsequently performed with fasciotomies the following day. The patient stabilized, but unfortunately had suffered an anoxic brain injury, and after much discussion with the family, he passed away on comfort care measures. Our small case series demonstrates the high morbidity and mortality of these rare penetrating subclavian artery injuries. Surgical approaches such as infraclavicular, supraclavicular, and thoracotomy exist to access the steep structure. Our series also demonstrates the various options for damage control such as shunt and ligation versus definitive repair such as PTFE graft. A role for endovascular intervention also exists in selected patients. Trauma surgeons should be familiar with the varied surgical approaches and treatment strategies for these challenging injuries. Thank you.
303 again.
So here comes the term damage control again. You know I'm probably against the extreme terms that we use.
Yes, sir, I do.
And if you're not presenting to a room full of trauma surgeons who love to speak damage control, then you're going to have a lot of people out there who don't understand or kind of dismiss the term per se. Perhaps due to the patient's extreme blood loss and tenuous physiology, decisions were made to ligate the artery, return to the ICU for warming, and continue with a bypass the next day. It's a nice term. I'm just usually, sometimes it just seems a little extreme.
Yes, sir.
Flo seemed a little better on that. The only thing I'd say is passed away is a dangling participle.
Okay.
Please
Died.
Succumb to his injuries or something like that.
Yes, sir.
Became deceased. Just like throwing up. It's a dangling participle.
You can throw down.
Certain circumstances, that's more appropriate.
Expired, yes, sir.
That was good.
Okay.
Yeah. Those are too good. All right. Yep. Luke Couch going next. Go.
Good morning. My name's Luke Couch. I'm a second-year resident at the University of Tennessee Chattanooga campus. This morning, I'd like to talk to you about the case of a 75-year-old male who presented for a colonoscopy following an episode of rectal bleeding and was found to have an adenocarcinoma of the transverse colon. A subsequent staging CT did not reveal any evidence of metastasis, and he underwent uncomplicated laparoscopic colectomy. Pathology returned as a T2 lesion without any nodal involvement, and he did not require any adjuvant chemotherapy. Surveillance colonoscopy at 10 months was roughly normal without any, with the only finding of a single sessile polyp. Approximately 1 year following his laparoscopic procedure, he represented to the ED with evidence of a high-grade bowel obstruction demonstrated here. He underwent laparotomy with findings of an obstructing mid-jejunal mass, which was resected, and a calcified area at the base of the mesentery, just distal to the ligament of Treitz, which was biopsied. Pathology returned with each of these specimens as pancreatic adenocarcinoma. Repeat CT imaging and a PET CT revealed a normal appearing pancreas and liver without any signs of metastasis. The patient underwent adjuvant chemotherapy. However, 7 months following his laparotomy, he represented with another high-grade bowel obstruction and was found to have diffuse carcinomatosis at this laparotomy. His family elected for comfort measures at this time, and the patient expired. This case represents an unusual patient who presented with 2 primary malignancies within a very short interval, one of which arose from presumed ectopic pancreatic tissue. Our search of the literature demonstrates that adenocarcinoma arising from ectopic pancreas in the jejunum is very rare. We only found 1 prior instance of a preceding colonic adenocarcinoma. I'd be happy to take any questions at this time.
2 minutes. That was 2 minutes and 19 seconds, so we got time to flesh it out. One thought I had, maybe worth talking about what his medical treatment was. It looks like we just resected a bunch of stuff, and then he was comfort measures. I'm sure he had some sort of chemo regimen that may be worth, it's not in the text at this point, but just mentioning that he underwent Folfox or whatever he.
I can do that.
Yeah. You've got
I don't
40
recall.
seconds to play with.
I don't recall exactly what it was off the top of my head, but I can just add that in.
Look him up.
I felt that when you described the colonoscopy, saying that it was relatively normal, and then, I think you can clean up that sentence and just say exactly what they found on colonoscopy, because it left me at least wondering what the hell you were talking about relatively normal meant. So if they underwent a colonoscopy and found that particular polyp, you're done. It doesn't leave it open for, was it a strange looking anastomosis? Was it, what did you mean by that? So I think you can put that in anyone's mind.
One thing that you could add in there too is that in the outcome portion of everything, during that 7 months, he was undergoing adjuvant chemotherapies. He was also undergoing surveillance, scans and stuff like that showed no evidence of recurrent disease. He had actually, I believe, had a PET scan maybe a month before he represented that did not show any obvious, recurrence.
Yes, sir.
Male is a generic term, female are generic terms. They can either be worms or squirrels or rabbits, but this was a man.
Was a man.
So if you really want to be specific, you would say he was a 72-year-old man, not a male. Just saying. Not much of one. You should know, Dr. Moore.
Just in case the veterinarian school's got a parallel session.
So,
May I have a dangling horse?
the other thing is you might just say what kind of colectomy, like right colectomy, left colectomy, transverse
Yes, sir.
colectomy, whatever it is.
And looking at your title up there, as you got going, I thought you were going to be talking about an interesting case because 2 tumors of a different origin happened within a year of each other. But I think the fascinating feature of this is the ectopic pancreas tissue that you think led to the cancer of the pancreas. And I think it's almost, at least to me, it seemed like your title pulled me to the left, but you really wanted me to go right. The fascinating feature of this case is not that two tumors occurred in a year. It's the fact that this tumor occurred in ectopic pancreatic tissue, right?
Yes, sir.
I don't know whether anybody else picked up on that or not.
Yes,
It's
sir,
just
did.
my thought.
Yes, sir.
If I'm listening to your poster presentation from the rounding attending, first thing I'm going to ask you, how in the world, why do you think this was ectopic pancreas? Why wasn't this just an occult pancreatic primary that you never found with metastasis? That would be far and away the most common thing. So how, I don't understand from your presentation, how did you all figure out that's what it was and not just a MET?
Primary pancreatic lesion.
No, sir.
That you saw on that you saw. I mean, I'm gonna ask you questions about the whole. I think you need to make that more clear. I don't know if you can.
You can. Yeah, so the pathologist saw ectopic pancreas tissue within the small bowel that was normal, and within this nest of ectopic pancreas tissue was this adenocarcinoma that was pancreatic in origin.
Okay, you got to make that
Yeah.
clear. I didn't,
Yeah,
I didn't
sorry,
understand that at all.
and
I
the-
think, I'm listening to this thing thinking, what are you guys talking about?
Yeah.
It's just metastatic pancreas.
Yeah, and that's a good point. The other point I would make too is that the carcinomatosis was biopsy proven pancreatic cancer, not. I would maybe specify that too, that the recurrence was of the pancreatic cancer, not of the colon cancer.
So I think you have a couple things there. You've got two things you can truly stress: ectopic pancreatic tissue causing adenocarcinoma, and two primary malignancies within a year, and the ectopic pancreatic tissue having a normal PET scan prior to finding it, and stress the ectopic of it all, the normal pancreas on other imaging. So I think you've got a lot more you could stress in the in poster and make it a lot more interesting.
Yes, sir.
But I did think your delivery was steady. It was slow enough to understand, and that's the way you need to speak when you do that.
Good morning. My name is Richard Tanner. I'm a third-year surgery resident at the University of Tennessee at Chattanooga. Today I want to talk to you about an interesting case of an inflammatory fibroid polyp that caused an intussusception. Our patient was a 50-year-old female with a 3-day history of right-sided abdominal pain with associated nausea and vomiting. On physical exam, her abdomen was distended and tentative palpation in the right lower quadrant. A CT scan showed an ileocolic intussusception as well as evidence of partial small bowel obstruction. She was taken to the operating room, and on exploratory laparotomy, the intussusception was reduced, revealing a large palpable intraluminal mass that was approximately 10 centimeters proximal to the ileocecal valve. This mass was exteriorized via an enterotomy and found to be approximately 8 centimeters long, as you can see in Figure 1. This section of small bowel containing the mass was resected. The pathology report revealed a polyploid lesion arising from the submucosa with mixed inflammatory infiltrates and spindle cells. There was no dysplasia or malignancy found. The microscopic images showed a whorled or onion skin appearance, which you can see in Figure 2. Together, these findings were consistent with the diagnosis of inflammatory fibroid polyp. Inflammatory fibroid polyps, or IFPs for short, are benign intraluminal neoplasms that are found in the submucosal layers along the GI tract. They are rare, idiopathic, localized, and non-recurring lesions. They can occur anywhere along the GI tract, most commonly in the stomach, then in the small bowel and colon. IFPs become symptomatic when they increase in size. When found in the stomach, they can cause abdominal pain. When found in the small intestines, they can cause obstruction and intussusception. Only 85 cases are found in the literature of inflammatory fibroid polyps causing intussusception. It's important to properly diagnose IFPs as they can mimic other lesions of the GI tract, some of which are malignant. Most notably, IFPs and gastrointestinal stromal tumors or GIST tumors appear very similar both microscopically and macroscopically. Immunohistochemical staining can be used to differentiate between the two. Both types of lesions stain positive for CD34. They can be differentiated by their staining to CD117. GIST tumors stain positive with CD117, whereas inflammatory fibroid polyps are negative for CD117. For inflammatory fibroid polyps, the definitive treatment is surgical excision. Thank you.
Two minutes, 40 seconds.
Richie, I was a little confused about exactly what you did to get rid of this. I missed it. Maybe I wasn't listening carefully enough. But did you locally excise it, or did you do a sleeve resection of the small bowel, and did that interfere with the ileocecal valve?
So we reduced the ileocolic intussusception, palpated the lesion, exteriorized the lesion via an enterotomy, and then resected the piece of small bowel on either side of it, and then primarily anastomosed it, and it was proximal to the ileocecal valve. A segmental resection.
I don't know that
That's the term. Yes, sir.
I don't know that exteriorizing it is like the oncologic approach that you'd want to do. I think I might just leave that part out and just say you resected the bowel containing the lesion and did an anastomosis.
The only problem I have with that is I've got a picture of it exteriorized.
Well, that you could say a picture here on the back table.
The only reason we did that is it did not appear to be a cancer. We couldn't tell what it was. It almost was like, it really just felt like this kind of object inside the lumen of the bowel. It did not feel like it was even attached to the wall of the bowel. It almost felt like a foreign body.
Well, that's that turned out to be the right answer because you had a limited resection, but that's going to be the question you're going to get. So you got to be prepared. Either you got to address it and tell why you did it the way you did it and didn't follow the normal oncologic principles, or you got to be prepared to answer the question because that is the one question you're going to get. It's probably the first question you're going to get.
As a veteran of presenting intussusceptions at the Southeastern, they will ask why you reduced the intussusception. The classic teaching is not to reduce it. In our case, we couldn't get to it. It was so stuck down. But that was one of the first questions I got. And I think as far as exteriorized thing go, I think you can say an enterotomy was made to better evaluate the nature of the mass, as we had a hard time telling or something.
Well, I would say just that you were concerned it was a foreign body.
Yeah.
In which case, the least morbid thing would be to do an enterotomy and extract it and not do a resection. Although a foreign body would be really unusual, I think, to do an intussusception. But
so I'm not a pathologist, but I'm not sure that all GIST tumors are positive for CD117. In fact, I'm pretty sure they're not all positive for CD117, which is why they check for CD34. So you might want to check on that and see if there's any other ways that you can differentiate between GIST tumors and IFPs.
The whole staining thing was a little laborious there at the end. The whole staining thing was laborious there at the end, so I would be very clear on that. GIST versus that and this staining, and be more about the surgical findings.
Yes, sir.
So would there be any role for frozen section in evaluation of these guys to make sure you did an appropriate oncologic resection?
Good question. I have to read into that.
I think you'll be asked that.
Yeah, I think so. Our issue here was this was in the middle of the night, and I don't know if you've ever dealt with our pathologist here on trying to get them in here to do a frozen section, but they're not real keen on that. But we took it about 3 or 4 centimeters proximal on each side. I mean, to give at least a little bit of a margin of error. And once we opened it up and kind of took a look at it, it did not have any type of gross cancer appearance. I mean, it just wasn't a very concerning lesion once you looked at it.
I guess if I was the guy at the poster as well, I'd ask you, after we worked our way through why you did what you did, what were you going to do if it came back as a gist?
Well, the treatment for a gist tumor is resection, and then if you had positive margins or if you had evidence of metastasis, you could do a tyrosine kinase inhibitor is the treatment for that.
Sorry, you told me what the treatment was. You didn't tell me what you were going to do if it came back as a gist.
I think that the treatment for, depending on the pathology, if it came back as a gist with negative margins, I think we've done what
Okay.
you're supposed to do.
All right. I needed to know what you were going to do, not what all the possibilities could be.
Yes, sir.
Any other questions? Thank you very much. This should be somewhat inspiring to some of you out there who are younger individuals who be going to Southeastern. Southeastern traditionally is resident friendly and has been. It's a good place to present. It's a good place to get up in front of people and have to answer questions, because you will get questions from people you don't know that come from other parts of the Southeast and some of them in the North. And you've got attendings here that are willing to work alongside with you, and it gets you a trip somewhere. You know, sometimes Southeastern in the middle of winter is somewhere warmer. Okay. Any other questions?
Just another promotion. The reception Monday night is at the NASCAR Hall of Fame.
All right.
I'm pretty sure they allow hanging participles there.
Oh yeah. 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 If you ain't cheating, you ain't trying. Yeah. All right. Okay, that's it, I reckon.
No, we got one more.
Oh, sorry. He's got two doubling up.
Yep. All right, so my name is Richard Tanner. I'm a third-year surgery resident. Again, good morning. My name is Richard Tanner. I'm a third-year surgery resident, University of Tennessee at Chattanooga. Today I'd like to talk to you today about an interesting case of an anterior mediastinal teratoma in an infant that became infected with salmonella. Our patient is a 2-month-old female with a prenatal diagnosis of a right cystic lung lesion who presented to the emergency department with a 5-day history of fevers and worsening respiratory distress. CT scan revealed a large anterior mediastinal mass with calcifications, which was consistent with a possible teratoma, and that can be seen in Figure 1. The patient was admitted to the ICU, started on antibiotics, and urgently prepared for surgery. The next day, the mass was excised via median sternotomy. It measured 10 by 7 centimeters in size and had both cystic and solid elements. Cultures of purulent fluid from the chest were obtained as well intraoperatively. The pathology report revealed a mature teratoma, and the intraoperative cultures grew salmonella. The patient did well after surgery and was discharged home on post-op day 6 after completing a full course of antibiotics. Teratomas are germ cell tumors that contain all 3 germ layers, the endoderm, the mesoderm, and the ectoderm. The incidence of teratomas is 1 in 4,000 live births, and about 18% are found in the neck and mediastinum. Most teratomas are benign and incidentally found and become symptomatic with rapid growth. Common symptoms include cough, chest pain, respiratory distress, and recurrent pneumonias. There are very few case reports in the literature describing infected teratomas, and we were unable to find any case reports of mediastinal teratomas infected with salmonella. Our patient's prenatal diagnosis of a right cystic lung lesion was actually an asymptomatic mature teratoma. After becoming infected with salmonella, It grew rapidly, which led to respiratory distress from mass effect. Our patient had an exposure at home to chicken coops, which could have been the source of the infection. Salmonella is known to be associated with reptiles and birds. In conclusion, infected anterior mediastinal teratomas are rare. Once infected, they may experience rapid growth, which can cause life-threatening compression of vital structures such as the heart and lungs. The treatment for these masses is surgical excision and antibiotics. Tumor recurrence for mature teratomas is unlikely, and 5-year survival rate is nearly 100%. Thank you.
$2.43.
So is it too late to change spelling on yours as well?
Yeah. What did I spell wrong?
Chicken coop.
Did they overthrow the chickens?
Chicken coo. Yeah.
Could be. Could be. Chickens had taken over and subverted and overthrew them.
It's a good job, Tanner. Make sure you have a differential of anterior mediastinal masses ready for a question.
Okay.
Good job on the manuscript as well. Remember, there was a chest x-ray that showed a large thymic silhouette, which probably was somewhat complicating the picture as well. So,
You mentioned that this patient was discharged home on post-op day 6
Yes, sir.
after a therapeutic course of salmonella.
Yep. So
therapeutic course of antibiotics for salmonella.
Yep. So it was a 7-day course, and it was started the day before surgery. So
Okay.
it's got 7 total days of antibiotics.
Okay.
a comment and a question. You said urgently prepared for surgery. Minor detail, but urgent means less than 4 hours. So I think you just say prepared for surgery the next day.
Yes, sir.
And just the question is, so this child had a known diagnosis of that thing and went home from the hospital with that, or I thought you said
The baby had a prenatal ultrasound and MRI that showed a right cystic lung lesion, and after the baby was born, was in zero distress, was completely asymptomatic, had a chest x-ray that showed a wide silhouette in the mediastinum, then was followed up with Dr. Kuntz at 1 month of age and was still asymptomatic, and the chest x-ray remained unchanged. And it was recommended the baby follow up in 1 year for another follow-up visit.
So that's why I said mention that, because that probably was the teratoma,
Right.
but still not an unusual X-ray for the baby.
How does this get infected, and what antibiotics was the patient treated with?
So the baby had salmonella, which is very rare. We found no cases of that at all. The best we can gather is the family has chicken coops, not coos, and there's a known.
Inhalation, is that the way it? Or
No, it's fecal.
injection?
Salmonella is fecal oral, typically. And then there was a second part of that question that
Strange diet. What
treated
what
with Rose-
antibiotics was the patient treated with?
Rosefin was the recommended antibiotic.
Richard, you need to read that through a few more times. You were halting through your talk. Your first presentation came off smoother, so you need to get a little better command of this before you do this.
Yes, sir.
Anyone else? All right, well, thank you. I think this is a good exercise both for the people presenting as well as we get to see what they're presenting and see their presentation. Like Dr. Moore said, Southeastern can be a lot of fun. I've presented there several times. It's a free trip somewhere cool. So you get posters, you get presentations on, and you get to go hang out with Darrell Waltrip.
that was a great job by everybody. Just want to make a note, probably most of you have heard, but the ABSITE scores are in, so you'll probably be getting a report to your box soon, and just wanted you to be aware.